So post-operative pain is important for any surgical intervention. And as far as cardiothoracic surgeries are concerned, it is critical because the chest case contains the heart and the lungs, which are very vital for the recovery in the post-operative period. And if we look at the key challenges, key post-operative challenges after cardiothoracic surgery, these include respiratory complications, hemodynamic instability, prolonged ICU or hospital stay, and also persistent post-operative pain, which is very common after cardiothoracic surgeries, and its incidence is somewhere around 40% at 3 months to 20% at 2 years after the cardiothoracic surgery. And all these challenges or complications increase if we don't maintain the adequacy of post-operative pain management. Hence, pain management perioperatively is very important. So these are the analgesic modalities. A combination of systemic and regional analgesic techniques is primarily used as far as pain management perioperatively of cardiothoracic surgeries is concerned. I will discuss salient features of these modalities individually. And towards the end, I would like to discuss few of the regional analgesic techniques, which are being more commonly used over the past few years. So first of all, paracetamol, we all know that it is the safest analgesic which is available with us. And though it offers modest pain relief, but it should be used because it helps in decreasing the perioperative opioid consumption. Then the NSAIDs. NSAIDs are a better analgesic as far as paracetamol is considered. But owing to its side effect profile, specifically the platelet aggregation, its use in cardiac surgeries especially is advised that it should be used with caution. So that's one point that should be considered always while and before using NSAIDs. Now, opioids are the traditional analgesics which are basically used in cardiothoracic surgeries, and with the definite side effect concerns, including nausea, vomiting, pruritus, and respiratory depression, they are going to delay the recovery in the post-operative period. So that's why this opioid sparing strategy is there, that we should use opioids, but higher doses of opioids should be avoided in the perioperative period. And drugs like dexmedetomidine help us in limiting the doses of opioids which are being used perioperatively, because it's a very good analgesic, and side by side it carries lesser respiratory depression effects. So it helps in limiting the doses of opioids while during these surgical procedures. Now coming on to the regional analgesic techniques, this thoracic epidural analgesia is a very good modality and provides very good analgesia, and also it helps in facilitation of early tracheal extubation. But despite this fact, its use in cardiac surgery has not gained very acceptance because of the associated risk of epidural hematoma. Hence, the advice is that whenever one is considering the use of thoracic epidural analgesia, always consider risk-benefit ratio with respect to an individual patient. So that's very important. Intrathecal analgesia is a very nice choice because it though offers modest post-operative analgesia, but it helps in reducing opioid requirements in the initial 24 hours. And also it doesn't have major adverse events or effects, specifically morphine, which we use for this purpose in the doses of 5 to 10 mics per kg, provides us very good analgesia with very little side effects. Paravertebral analgesia also offers good analgesia, which is comparable to the thoracic epidural analgesia and very minimal side effects. And it is useful in all these cases, surgical interventions. And also there is negligible possibility of epidural hematoma associated with paravertebral blocks. Local anesthetic wound infiltration, we basically in this with this modality, catheters are placed at the site of the wound and continuous local anesthetic infiltration is done. And it helps in improving pain scores with reduced opioid consumption. But despite that, this technique is not very commonly used because of the associated seepage of local anesthetic through the site of wounds, and also the fear of infection with the catheter. So probably this may be this may offer more benefits, but more research is required, specifically in the area of the side effects which are associated with it. So these are the techniques which I have discussed so far. And over the past few years, interfacial plane blocks have been very commonly used for the perioperative pain management. So I shall be discussing the basic facts associated with this interfacial plane blocks, and then the recent evidence which has come up for individual techniques. Well, interfacial plane block, local anesthetic is basically injected in a facial plane. And this is usually done under real-time ultrasound guidance. And this local anesthetic basically blocks the nerve fibers which are running in a specific facial plane. So the basic concept is that spinal nerve ventral rami give rise to the intercostal nerves, and these intercostal nerves, which provide somatic supply to the thoracoabdominal wall, basically run in different muscular facial plane. During its course, and it's also give branches, and all these the intercostal nerve and its branches are running in specific muscular planes, and at various sites we can target the nerve or its branches to provide a variable somatic block depending upon our requirement. So what are the basic advantages? It is technically easy because it is being performed in a superficial target plane. Then it's safe because it is away from major vasculature and also from the central neuraxis. And there is less risk of bleeding, especially in the presence of anticoagulant therapy, because the target planes are superficial, they are compressible. And finally, side effects are less, especially the hypotension, because these are the primarily somatic blocks. Autonomic nerves are not blocked, so hypotension incidence is less. Few lacunas, it is less potent than a central neuraxial blockade. There is, because it's primarily a somatic block, so visceral pain is not addressed. And finally, the response is unpredictable because the response depends upon the spread of local anesthetic in a facial plane. So these three blocks are primarily used for different cardiac surgeries, and I shall be discussing the salient feature of each block followed by its evidence. So first of all, the rectus spinae plane block. Well, this block, local anesthetic is injected in the plane between a rectus spinae and transverse process, 2 to 3 centimeter lateral to the spinous process, as you can see over here. And it provides, it basically blocks both the dorsal and the ventral rami, and it provides somatic block along whole of the chest wall. So it is a very good modality for both the median sternotomy and the thoracotomy. And if you look at the evidence, this randomized control trial, which has studied the role of rectus spinae plane block for patients undergoing adult cardiac surgery via median sternotomy, the authors found that it provided good pain relief as compared to systemic analgesics like paracetamol and tramadol. Then this randomized control trial has compared rectus spinae plane block with thoracic epidural analgesia, and it has concluded that the ESP block provided comparable pain relief to thoracic epidural analgesia as far as medial sternotomy surgeries are concerned. So good evidence is coming up as far as the use of rectus spinae plane blocks for median sternotomies are concerned. Then this serratus anterior plane block. Here the local anesthetic is given either superficial or deep to the serratus anterior muscle. These are the two planes where the local anesthetic is injected along the mid-axillary line, and it blocks the lateral cutaneous branches of the intercostal nerve, and it provides analgesia along the anterolateral and the posterolateral chest wall. The midline anterior is spared, so it provides good analgesia in cases of thoracotomy or the minimally invasive cardiac surgeries. We did this randomized control trial where we evaluated serratus anterior plane block for pain relief in patients undergoing minimally invasive cardiac surgeries, and we found that SAP block reduced postoperative pain scores and opioid requirements as compared to systemic analgesics in these patients. Subsequently, a good number of studies are there which are supporting the use of SAP block in minimally invasive cardiac surgeries, and they are telling us that it is a simple and safe alternative to neuraxial and paravertebral analgesia in patients undergoing minimally invasive procedures. Finally, the parasternal block. Here, a local anesthetic is injected lateral to the sternum between pectoralis major and intercostal muscle, as you can see over here. And it blocks the anterior cutaneous branches of the intercostal nerve, thereby providing sensory block along the anterior chest wall. Hence, it's a very good analgesic option for median sternotomies. And regarding the evidence, this systematic review and meta-analysis published in 2022, it has included around 18 RCTs who have evaluated the role of parasternal block for median sternotomies. And they have told us that PSB helps in reducing postoperative pain scores and opioid use after cardiac surgery. So a considerable amount of evidence has came up for the use of parasternal block for median sternotomies. So here in this picture, a combination of interfacial plain blocks have been used for post-operative pain relief after robotic-assisted cardiac surgeries. 2 or 3 interfacial plain blocks have been used, but the only thing to be considered is that a large amount of local anesthetic dose has to be used. So local anesthetic toxicity should always be kept in mind, and local anesthetic should be used appropriately. So if you look at the rational approach, multimodal analgesia is the answer, and a combination of analgesic drugs should be used to achieve good analgesia with minimal side effects. So these are the options I have discussed earlier on. So our basic goal for perioperative pain management should be a combination of drugs from this box, along with any of the regional analgesic techniques which are available based on the proper sensory block which it is given. So to conclude, multimodal analgesia approach should be considered, and the drugs which are appropriate to be used include paracetamol, opioids in the form of tramadol or intermittent fentanyl, intrathecal analgesia, and interfacial plain blocks. For median sternotomy, ESP block and parasternal blocks are useful. For minimally invasive cardiac surgeries, electrospinal plain block and SAP blocks are useful. Well, interfacial plain blocks, these are the simple and safe technique. Less potent analgesia as compared to irregular blocks, but it helps in reducing opioid consumption in the perioperative period in a multimodal pain management model. And since large amount of local anesthetic solution is used, local anesthetic dose should always be kept in mind. Thank you very much.